Okay, so very quick overview of what we're going to talk about today. So we're going to briefly kind of go into what we're talking about when we're saying STIs, and also how we kind of talk about that with community and general population as well. We're then going to go through an overview of STIs and WA. So we're going to do a bit of a snapshot of each different STI, most common STIs that we talk about. And then we're going to collectively look at contact tracing notifications and things like that, and then where you can get supports and other resources to turn to as well. If you have any kind of questions or you want to find out more information too, and then of course taking questions at the end. So ready to jump in?
Let's do it.
Let's do it. So very briefly, I guess for many of you jumping on, you probably are aware of what an STI is. It's kind of having a bit of a breakdown here of how we explain STIs to general population, a lot of the workshops that we do. Of course, talking about STIs is a sexually transmissible infection. So these are infections that are passed on from one person to another, primarily through sexual contact. We know some STIs also are blood-borne viruses as well, so it can be transmitted through blood-to-blood contact. But generally, when we say STI, we're talking about those infections that are passed on primarily through sexual contact or intimate contact. The reason we use STI, not STD, there's a few different reasons for that. Still, you might see on some sites, and even some medical sites, particularly the US sites, will have STD still listed there. Reason we use STI, and we're trying to encourage more to use STI, is one, we're talking about infections, so it's technically a little bit more correct. And also we use the term disease, so STD. The word disease has quite a lot of, is quite a heavy word and quite a stigmatized and quite scary word. And seems like something that maybe can't be cured, or maybe that is going to have quite horrible effects. But really, when we're talking about infections, we're talking about STIs, we're talking about, the germs or the bugs that can pass between people, and then they can be treated, they can be managed as well. So there's a couple of reasons why we prefer to use the term STI. So there's different types of STIs. We'll go through them today. So there can be bacteria, they can be viruses, there can be parasites as well. And these kind of tells us, when we know bacteria, virus, or parasite, can tell us how they can be treated or how they affect the body. Again, there's so STI, not STD. And also, when we talk to the general population and community about STIs, often they use that extra layer of stigma around these infections, as opposed to a lot of other infections we get throughout our body. We know that it's not just because of that actual particular bacteria or that particular virus, it's because of the behaviours that they're associated with. So we're talking about infections that are primarily passed on through sexual contact, or for blood-borne viruses, infections that may be viruses that may be passed on through blood-to-blood contact, which could be associated with behaviours such as drug use. So often that is kind of that stigma is kind of that kind of weight is often really added to the behaviours it's associated with. So we really want to be, if we want to kind of address the stigma and the kind of discomfort that a lot of people have around STIs and blood-borne viruses, we really want to be addressing that stigma around those behaviours as well, and that shame, and how we can navigate that as both as professionals and also community members as well. Compare it to things like COVID, you're talking about a virus there as well, but no one was afraid to put up a photo of their COVID test when they tested positive on social media. You might have very different social media channels to what I do, but I didn't remember anyone putting up a gonorrhea test or a chlamydia test, something like that. So when we're talking about testing for infections, but because obviously one's associated and one's kind of okay to talk about, and the others for some reason aren't always as okay to talk about. So just want to keep that in mind, both as professionals, but also as community members as well. So we'll get started into talking about the actual STIs. So we'll start off with chlamydia. So what we'll do for each one, we'll go through a bit of the epidemiology, the trends around the STI, and then I'll hand over to Garry to go through testing, symptoms, kind of clinical presentations, and also the treatment as well. So we'll do a bit of a snapshot and overview. I will also send out these slides at the end of today, hopefully, so that you'll have this image here, which may be a helpful reference point too for you. So with chlamydia in WA, there has been a bit of an increase in chlamydia of the last 5 years, or compared to the last 5 years. So the data that we have here is from the Department of Health, and it was pertaining to 2024. The highest notifications with chlamydia and kind of historically have often been in that kind of 15 to 29 year age gap, or age group. The rates have mostly remained stable across different regions around WA. There was in last year a bit of an increase in the Goldfields and also in the Pilbara as well. And also the notifications are slightly higher in females compared to males. So again, notification rates there could be different reasons for that. One could be around testing around reproductive age. Others could be the present difference in kind of presentation of symptoms causing people to get tested. Some possible theories there. But I'll hand over to Garry now to talk a bit more about the clinical aspects of chlamydia.
Okay, so, excuse me. So chlamydia is the number one most popular infection around the world. So in WA, anywhere between about 10 to 12,000 notifications each year, somewhere up to about 100,000 in Australia each year. And that's only what we find. So there would be many more that we would find if people were getting tested. And I think one of the reasons why it may be notifications higher in females is that they may tend to be more likely to go and get tested than particularly younger males. So with, the potential symptoms, it's always really important to remember that a significant number of people are asymptomatic. So you'd wonder, why do we bother testing for something that has no symptoms? Because it can cause severe symptoms in some people, can cause moderate to severe anorectal pain, bleeding, discharge, can cause urethritis in people with penises, may get some discharge. Repeated chlamydia infections in the urethra in males can lead to infertility, and there's also a potential risk for pelvic inflammatory disease in people with a uterus, and could lead to infertility. So, but so we've got on the slide there where you can have some discomfort on urination, discharge. It's usually a clear, like white or clearish discharge, and pelvic pain and dyspareunia. I love that word, which is pain during vaginal sex. So so we always test throat swabs. We do rectal swabs, vaginal swabs, and urine tests. And the good thing for females is that it's a self-collected vaginal swab for most people. So, and I often talk to people that basically anything that goes anywhere, whether it's fingers, tongues, toys, etc., is always a potential transmitter. That also goes for gonorrhea as well. So the preferred test is always a PCR test. So we swab every orifice, basically. And, excuse me, so I've just got a bit of a thingy at the minute. And then rectal swabs are easily self-collected as well. So the gold standard treatment is 1 week of doxycycline, which is 1 tablet twice a day for 7 days. The reason why that has become the preferred treatment is because of azithromycin. There's certain bacteria that have become quite resistant to azithromycin, but we do use it if people have some kind of allergy or other reason that they can't take doxycycline. So it's 1 tablet twice a day for 7 days. The recommendation is to avoid any sexual contact for 1 more week after completion of treatment. And a lot of clinics will do a routine test of cure, but people have to abstain for a full 5 weeks. And I know a lot of our clients are not particularly keen on that, but we do know that treatment's highly effective, particularly with doxycycline. So it's not routinely recommended to do a follow-up test unless it's somebody who's pregnant, or often in female partners where there is that risk of pelvic inflammatory disease, etc. And anyone who's come up positive with any of these infections, what we call a test of reinfection is always recommended at 3 months. So have we covered everything there? I think we've covered it all. Yep. Okay. Cool.
On to gonorrhea. So gonorrhea there's been increases in gonorrhea in WA across Australia, but looking specifically at WA the last few years. So in 2024, the Department of Health reported that there was a 36% increase in notification rate compared to the previous 5 years, or previous 5-year average. And this includes an increase in the test positivity rate as well. So the trends, Department of Health was saying that the trend suggests that the increase in notifications was due to both an increase in testing, but also an increase in disease transmission as well. So there's been, within that, there's been an increase primarily amongst males and remained relatively stable amongst females. There tends to be higher notification rate amongst males compared to females. That's kind of an ongoing trend there. And in terms of the age groups, the predominant kind of age group is between 20 to 34, with the highest amount of notifications. So they counted in 2024 for about 58% of gonorrhea notifications in WA. It's important, I guess, addressing this with the increase increase in gonorrhea. So we'll get into treatment a little bit more in a moment, but gonorrhea has quite a high affinity to develop antimicrobial resistance. So we are quite limited now in terms of the treatments available for managing gonorrhea. We're quite lucky, particularly in some regions around WA, that we do still have, I guess, treatment kind of opposite to resistance, I guess, susceptible to treatment and effective treatment, and including in metro area as well. But with the reintroduction of overseas travel, there is that risk there of other strains of gonorrhea coming into WA as well. So it's just something that we want to be aware of and kind of getting on top of before it kind of gets to that point there.
Indeed. Okay, so as I said, well, gonorrhea is the second most common infection that we find, and often in most often in throat and rectal infections and vaginal infections can be asymptomatic. So this is why when people say, I don't have any symptoms, I'm sure I'm fine, means absolutely nothing. So we pick up a significant number of rectal and throat. We don't see a lot of female or people with vaginas here, but so it's mostly men or people with penises that we see here. So with the potential symptoms in men, in a urethral infection, about 90% of people will get quite a mild to significant nasty purulent discharge, and this is what drives people to come in. It can be really unpleasant, can be incredibly painful. So we do a urine test for that, but one of the main things we need to do is take a swab of the discharge, and that gets cultured at the lab. And the benefit of that is that there are other infections which can also cause similar symptoms or be concurrent infections such as a streptococcus or staphylococcus. And occasionally we see people with significant discharge that it's not an STI. So taking a swab and doing a slide of the discharge is incredibly important. Sometimes it comes up with this really weird bacteria, and it wasn't gonorrhea, so we can differentiate, but also helps us to target the treatment. And one important thing with gonorrhea is that thankfully in Australia that we don't have or haven't seen many cases of resistance. Other parts of the world have had significant issues with microbial resistance. So for as long as I've been around, we've been treating gonorrhea with ceftriaxone injection plus 2 tablets of azithromycin. We're also lucky now that Pathwest does antibiotic resistance testing with gonorrhea, and we've had a significant number which are sensitive to another antibiotic called ciprofloxacin. Sorry for the terminology. And it's a single tablet, 500 milligram, and that sorts it out. So this is where Pathwest is fabulous, because we can actually target the treatment. whereas ceftriaxone is a broad spectrum antibiotic, so it's really good to be able to avoid using that if we know that we can treat it with the single tablet. So I think, oh yes, sorry. After treatment, no sexual contact for at least 7 days. And again, test of cure is not routinely recommended. And again, retest at 3 months for checking for potential reinfection. So I think we've covered most of that.
Yeah.
And
so with the treatments as well, there is still some regions, so the Kimberley and the Goldfields, where the guidelines are still permitting to use the ZAP packs for treatment of gonorrhea. All the other regions within WA, it is the treatment that Garry was describing there with the ceftriaxone and then the oral antibiotic as well.
Yep. Cool. Right.
Alrighty, on to syphilis. So syphilis, I'm sure has probably been on many of your kind of radars. Hopefully it has been, not so, especially the last few years. So we have had a syphilis outbreak in WA the last few years. So comparably, if we're comparing 2024 to the previous 5-year average, there was a bit of a decrease in the notification rates. So a slight decrease, and the trends were suggesting, Department of Health said that the trends suggesting that it may mean that there has been a bit of a decrease in disease transmission, which is great. Still though, it's comparing that kind of 5-year average, the 5-year average has been throughout the outbreak as well. So we still are seeing higher cases than we were seeing prior to the beginning of the outbreak a few years ago. So we're still wanting to continue. So it's not kind of take the foot off the brake, it's very much continue the work that we're doing and to continue to keep bringing syphilis cases down. In terms of the trends, there hasn't, where was I? So there's been a slight increase in male notifications, but then there's also been a decrease in notifications amongst females. In 2024, there wasn't any congenital syphilis cases reported. However, there have been some, so it was quite good. I remember all us at the office reading that, and it was really great. There has, unfortunately, though, has been a number of cases that have occurred so far in 2025 as well. So it is still, wanting to work to bring down those syphilis cases and preventing cases of congenital syphilis as well.
Okay, excuse me. So syphilis would be, it's actually my favourite STI. It's fascinating. But just from a clinical medical point of view, and interpreting the serology can take quite a bit of detective work. But once you get your head around it, it's really interesting where you can work out the staging of infection. So the syphilis bacteria just needs to find its way into like a mucous membrane or a break in the skin. So it's primarily through, can be virtually any close, intimate sexual contact. So it's always important to know that, again, a lot of people don't get symptoms and are completely shocked and surprised when we do a blood test to find out that they do have syphilis. So if people do get a lesion at the beginning, so it can be, can look, so what we call it a chancre, but it can look like quite a nasty sore, and it's often like indurated in the middle. It's got a rubbery edge to it, can often look quite painful. Often it's not painful because the syphilis bacteria kill off the superficial nerves, so you don't actually, may not feel it. And if this lesion is somewhere where you can't see it, whether it's vaginal or rectal or in the throat, you don't know, and that lesion is actually teeming with syphilis bacteria. So what's really important is that anything you suspect may be syphilis, and sometimes it could just look like an unusual rash, swab it for syphilis, swab it for herpes, and the lesion will come up positive on a PCR before your blood test. So swabbing the lesions is really important, and that would indicate a very early infection. Even if people don't get this particular lesion, then after a few weeks or a few months, people can develop secondary symptoms where you get fever, muscle aches and pains, fatigue, and there's often a quite distinctive rash, which can be fairly localised. Some people have it quite widespread, can be on their hands, on their feet. It's usually quite typical, although you never trust them because sometimes it'll look like something else. So, or from my point of view, I always think, could this be syphilis? So now the thing to remember with syphilis is even though you develop an antibody response, it does not neutralise the bacteria. Chlamydia and gonorrhea, given enough time, will eventually clear, but how long is a piece of string? So you always want to nip it in the bud. Syphilis is not going anywhere, and it's important for people to know that if they're having more than one sexual partner, syphilis is always possible and can ultimately be fatal. So it can cause quite significant damage to virtually every organ of the body. So if it's not treated, and we can be talking decades, then it can develop into the tertiary stage, where, as I said, it can cause quite severe neurological, cardiovascular complications, can cause inflammation of the inside of the arteries, where it can weaken the arteries and cause hemorrhages, can cause syphilitic dementia, heart failure. So anyone who's ever been sexually active, even somebody you think, okay, well, you're 60 years old, you've been married for 30 years. If they've never had a syphilis test, just do one, because we picked up syphilis on people that they would swear that they haven't had any sexual contact for 20, 30 years. They've come out of a relationship, then we test them and bingo, they've got an old untreated infection. So the gold standard treatment for syphilis is good old penicillin, which is, thankfully, it's never developed any resistance to that. So usually if it's within 2 years of a previous negative test, and it's quite complicated to work out from a single blood test sometimes, but that would be definitely for another day. 2 injections of penicillin on the same day is usually enough. If it looks as if the infection's been there for many years, then it's you get 3 of these treatments over 3 weeks to ensure that the antibiotic has penetrated every part of the body, because it can cross the blood-brain barrier and can get into the cerebrospinal fluid. So we really hammer it if it's an old untreated infection. So the syphilis, we do whole webinars on syphilis. So if people want to sort of really dig into the nitty-gritty of it, more than happy to explain it at another time. But one of the things that's important is when we're looking at an early infection, or one that's within the previous 12 to 24 months, the RPR, it's the rapid plasma reagent test, which is allocated a number value. So let's say that starts out at a 64. It's a visual test, and then what we want to see is that number drop by 4-fold over the next 12 months. So we do repeat testing at 3 months, then at 6 months, and again at 12 months if necessary. So, but as I said, it's a little bit complicated to understand all of that. We don't really have time to go into all of it today, but I find it absolutely fascinating. So after treatment, whether it's an old untreated infection, then definitely once we've done all the treatments, that's fine. They can recommence sexual activity after 7 days. If it's an acute infection, no sexual contact for 7 days after treatment. If they're asymptomatic, if they had the lesion or the rash, then they must abstain until those symptoms are completely resolved. And contact tracing is absolutely vital. So when we have clients that have partners that are unaware of their sexual activity outside their relationship, we have to really impress upon them the importance of partners being informed that they're a potential contact of syphilis because of the potential complications that we've already discussed.
If you wanted to know more, like Garry said, there's quite a bit that goes into talking about syphilis, and especially around the testing and treatment of syphilis. If you want to know a bit more about this, when I send out the recording after the session for today, I'll also remember to link in to the session we did a couple of months ago, so where Garry did a deep dive into the testing and treatment of syphilis as well. So I'll make sure to send that out if that's of interest to you. So, cool. So talking about HIV. So HIV is human immune deficiency virus. Looking at the epi for kind of the trends around HIV in WA, there was an increase in 2024 of HIV notifications in WA, and this compared to previous year. Throughout, like with any kind of trends around across any of these STIs, the notifiable infections there, we did see a dip down or a decrease in notifications throughout the COVID period, particularly decreased travel and kind of, I guess it was a very different time there during that period. So we did see an increase of HIV in the last couple of years back up to the pre-COVID levels. But again, it is still at the risk there. We could be increasing there as well. There was an increase in notifications, particularly amongst males, and both MSM and also through heterosexual exposure as well. In terms of both where they're acquired, higher kind of rates of acquisition in Australia amongst MSM, but then also with heterosexual exposure, they're mostly being acquired overseas. Similarly as well with notifications amongst females, that a large proportion of those are acquired overseas, which is a trend we've seen over the last many few years, and particularly again looking at the return of overseas travel as well.
Okay, so what's something that's really important with HIV? We're very lucky in Australia. The rates are relatively low compared to other countries, but any amount of HIV is too much, clearly. So it's really important to know that up to around about 30% of people don't get symptoms. So we've diagnosed many people over the years that have said, I don't remember being unwell, I don't remember having the fever, the rash, the lymph nodes, muscle aches and pains, or the night sweats, which is can be quite typical. So anybody who's had sex without a condom and they think they're not at risk for HIV, then you can say, well, basically, unless you know the other person's status, that there is a potential risk, and no symptoms doesn't mean anything. So one of the important things also is regarding the window period. So you'll still see on official websites that the window period is 3 months, which drives me crazy. So the first HIV test back in the 1980s had a window period of 3 months. So we've now gone from the first generation to the second, to the third, to the fourth generation testing for HIV, which is an antigen antibody test. And we know that we can get, we would likely pick up HIV within 2 to 3 weeks, but we do a window period at 6 weeks. And in certain situations, you may be looking up to 12 weeks. And this is also where it may be information coming from other parts of the world which may not be using the same accuracy of testing. So so when you're ordering an HIV test, you can order HIV antigen antibody or just HIV serology. And the other occasion where we may push out a window period to 12 weeks is where somebody is immunocompromised or on, say, treatment for rheumatoid arthritis, where their immune response may be dampened. And in those situations, we've actually repeated the test up to 12 weeks. There is the self-test kit, the Aimee, which is, I think it's about $25, $30, available from pharmacies as well as WAAC. That has a window period up to 3 months. It is a screening, it's a screening test. It's not a diagnostic test. There can be a false positive or a false negative. So if people get a negative test, it's really important that they have that followed up with a serology test for certainty. So, so this is also something which is also really good news when you think about the bad old days, is that antiretroviral therapy these days is extremely well tolerated, it's extremely effective, and virtually there are occasions where people are diagnosed with AIDS in Australia because they've never been tested and they've never been on treatment. So the treatment is incredibly effective. It suppresses the virus down to a level where it's undetectable on a routine test. And most people who adhere to the medication will probably live, a normal lifespan with all the usual problems of getting older. There's also, so we've got the options of daily oral therapy, and there's also now Cabenuva, which is a 2-monthly injection, which is also highly effective. And there's other long-acting injectables which are coming into the near future. It may end up being a yearly injection. So things have hugely changed in that space. So what's important also is if people think they've had a high-risk exposure where they've had unprotected sex with somebody that don't know their status, then they can access PEP, post-exposure prophylaxis, which is the tenofovir and emtricitabine, which is the same medication that we use for pre-exposure prophylaxis. The medication has to be started no later than 72 hours after potential exposure, preferably within, as soon as possible, basically. So, and then we've got PrEP, of course, which when taken as directed is up to 99% effective in preventing HIV infection. And also important, U equals U, where people have an undetectable viral load, which international definition is under 200 copies of virus per ml of blood, cannot be transmitted through regular sexual contact. So it's incredibly important for people to know that somebody who's on treatment, undetectable viral load, the virus cannot be transmitted.
Yeah, and on that note as well, Garry, kind of going back to the kind of if you're looking at the trends that we and saying as well that we're very lucky in WA and Australia with access to treatment that we have and having comparably quite low case numbers and notifications. That is still, around the world there is a different landscape of HIV in different countries. But what we're aiming for globally is, and both within WA, in Australia and globally, is aiming for the virtual elimination of HIV. So the aim is to have virtually eliminating the occurrence of new HIV notifications, but also within that as well supporting people living with HIV to be able to accessing effective treatment and being able to reach that U equals U, but also then be able to sustain that and having good quality of life as well. So something very much is on the horizon. There's still work to do there, but for all of us in the community and also as practitioners. But it is something that we are kind of striving towards as a global community as well.
And I think in a country like Australia, we're very, very lucky with the access to really good testing and medical care. It is absolutely possible to achieve the virtual elimination of HIV in Australia. Unfortunately, other parts of the world, it's going to take much longer, which is a shame.
So I just had a question there, which I'll answer now. So in terms of achieving that virtual elimination, the date we're aiming towards is 2030. So you can look that up, the virtual elimination. So that by UNAIDS, they've got the targets there. So you can look them up. So they'll have like the 95 targets. And encourage people to look into that a little bit more. Next up, we have Mpox. So Mpox is a little bit relatively newer one on the scene. So it's a virus that is a notable infection. So we do have a bit of information about the kind of trends within WA. So globally, the outbreak of the Mpox virus started in 2022. It's predominantly, Mpox infections has almost exclusively been diagnosed amongst MSM. And being transmitted through, where it's been transmitted through sexual contact or other kind of close contact. So all notifications in WA for 2024 and also so far in 2025 have been mail. I believe it was the first kind of notifications or local transmission of mpox in WA. We only started seeing towards the end of last year as well.
So there were a few local transmissions. The first big outbreak in mid-22, but mid last year, big outbreak in the eastern states where you'd expect it, and then we had about 70 cases towards the end of last year, early this year. About 3 months ago, we had 3 local transmissions as well. So we've been incredibly successful with rolling out the vaccine. The uptake in the community has been enormous. So it's really important for anyone to be vaccinated. Even like people say, oh, there's not much mpox around these days, you don't hear much about it. Well, that's because we're vaccinating people. So it's the same as any infection like hepatitis B, we don't see much because we vaccinate. So where we're going now. So as far as the potential signs and symptoms, it's highly variable, where once people have acquired the virus, people can come out with a rash, can be pustules, rash, lesions, can be a few. They can be quite widespread. We've seen a couple of cases where people have had the lesions on their face, on their hands, torso, genitals, and in that case, people are really unwell, and those lesions are full of virus, and it means that they would have to completely isolate because you can't keep all of those lesions covered even if you're going out. But it can be quite mild, and if people only have a few lesions and are not terribly unwell, they may not think it's an issue, and then they're continuing to have close contact with other people. It's primarily through sexual contact because you need close proximity, but it can also be on other surfaces as well. So it just needs access to either broken skin or mucosal surfaces, so urethra, vagina, rectum, through the mouth, and one thing that's can be, we haven't had any cases like this in Australia, but other parts of the world have reported where the lesions have been in the mouth or the rectum, and it's apparently so painful people can't eat, can't swallow, can't defecate. Oh no, sorry.
It's all good. The computer's ringing. That's all right.
Ignore it. It's our HIV line. Somebody wants some information about HIV and syphilis, I imagine. Sorry about this. Okay. Anyway, that's completely buggered up my train of thought. So the symptoms, as I said, can be quite mild, quite severe. There is no treatment unless it's really severe. Antiviral can help to reduce the severity of the symptoms, but the common features are the rash, the fever, swollen lymph nodes, headache, muscle aches and joint pains. The vaccine is actually a smallpox vaccine, so it's related to smallpox. It's 2 doses, 28 days apart, and it's available to anyone who's within the sexual sphere of gay, bisexual men, sex workers, etc. So after the 2 doses, it's an average immunity level of about 85%. So when people are actually presenting with the symptoms, it's important to get a PCR swab of the lesion, specifically have a dedicated one for mpox. And we also test for herpes and syphilis because the symptoms and the rash and the lesions can look quite similar. So it's really important to test for both of those. Mpox must be put into its own separate bag and then bagged again and sent to the lab completely separately, just because of its highly infectious nature. So I think we've probably covered the rest of it there as far as treatment and management. Yep.
The next one we'll talk about is, so the next couple that we're going to finish up with aren't notifiable infections. So the ones we've spoken about so far are in WA are notifiable infections. So with the next couple one, we may not have kind of specific kind of epi or anything on it, but we have looked into kind of see where the trends and what we can say about this. So trichomoniasis, so it's a parasitic infection. Its highest prevalence in WA is in rural and regional areas. It's most commonly a vaginal infection, most commonly where it's tested and treated for. Yeah, especially if you're in regional areas, maybe something you're a bit more familiar with compared to maybe in metro areas. But yeah, hand over to Garry, go through symptoms.
Yeah. So the I think very few occasions that we've actually tested anybody here for trichomonas. It's most common in more remote areas up north. So again, we've got the issue of vaginal infections often being asymptomatic, and urethral infections can be asymptomatic. If people do become symptomatic, you can get quite an odorous vaginal discharge, which can be typically profuse and frothy. And can be itchy, painful, and again painful on sexual intercourse. So the treatment is metronidazole, which is an antibiotic, for 7 days, and again avoiding any sexual contact for 7 days after treatment. So if you have somebody that, say, a female who's been diagnosed, then you may have a male partner who's asymptomatic, then they both need to be tested, or both need to be treated to avoid the ping-ponging of the trichomonas back and forward. So yeah, and there's other potential issues where women can also have bacterial vaginosis. That's something I'll talk about a little bit about in a minute, where that's emerging more as a sexually transmitted infection versus just a syndrome. So again, so the high vaginal swab would be something that would need to be done preferably by a clinician, but it can be collected by the client if they decline examination. Urine test, and we don't do screening, routine screening, unless it's actually in high-risk prevalence populations, and definitely do not routinely test for people who have symptoms of urethritis until you've actually ruled out every other more common infection. So we don't go looking for something unless we absolutely have to.
Next up, we've got Mycoplasma genitalium. So it's a bacterial infection. Again, it's not a notifiable infection in WA, so we don't have the exact kind of trends within WA, but it is thought that about 1 to 2% of the adult population have it, making it about as common as chlamydia. So from the evidence and the research there, we're able to pull.
Yeah, so Mycoplasma is basically it's a pain in the ass. If ever it's mentioned at a conference, you can hear the whole audience go, "Oh God!" So it is sexually transmitted bacteria. One of the main problems is that it is highly antibiotic resistant. So very often asymptomatic. Symptoms that can include pain or discomfort and urination, some white or clearish discharge, urethral discomfort, and also signs and symptoms of pelvic inflammatory disease and cervicitis in women. So one of the, as I said, one of the big issues is that it's antibiotic resistant. A lot of men will carry it without any symptoms, and it's not considered to be a pathogen if people are asymptomatic. So we never routinely test for it on an asymptomatic screen, and we don't routinely test for it even if somebody is symptomatic unless we've ruled out chlamydia, gonorrhea, or other infections. Then if the symptoms persist, then we'll test for it, because it's pretty hefty treatment of a week of doxycycline followed by another antibiotic called moxifloxacin, which costs about $140. It's not on the PBS, and it can be, it's a lengthy treatment. So, but for women or men that have female partners, then it's really important that they then have a follow-up test of cure, which can only be done at about 3 to 4 weeks after completion of treatment. Yep.
Last one we'll talk on, and Garry just did mention briefly before, around bacterial vaginosis. So we've got about listed as a syndrome. It's kind of a watch this space at the moment. There has been some recent research that has been released suggesting, or kind of around looking at bacterial vaginosis as an STI, or looking at it as, and also around like treating partners. So there's interesting research coming out, very much a watch this space kind of thing. It does have a relatively high prevalence, particularly amongst women or people with vulvas of around reproductive age. And like we can see here as well, is quite commonly can be asymptomatic, but obviously can occur with symptoms there as well, which are listed too.
Yeah, so it's often been, as Aimee's explained, just as a syndrome, where you get an imbalance of the normal bacteria in the vagina. So the lactobacillus, the lactobacillus species of bacteria, well, everything needs to be in balance. So if you have a lack of lactobacillus, which maintains the acidic environment of the vagina, then the other species, such as these fabulous ones called Gardnerella, Bacteroides, Mobiluncus, they overgrow and start to cause symptoms, and it can be quite a noticeable fishy odour that people can get, and a grey or whitish discharge. So it's previously not been considered an STI, but they've actually done quite a bit of research in heterosexual couples, where if you have the male partner who's carrying some of these other bacteria, that they're then basically reinfecting or reintroducing those other unwanted bacteria during sexual intercourse. And so they're now looking at the importance of treating the male partners, and it could also be female-female couples as well. So it's heading more towards being sexually transmitted infection, but again, as Aimee said, it's more of a watch this space. So I think so diagnosis, if you ever think that it's BV, that you must do a culture swab and put that onto a slide, and then they can actually look at the slide, and there's a specific sort of morphology that they see that helps to diagnose BV. I think what else we've got? Yep. Okay. So, and then treatment.
There's a few different treatments.
Yeah.
So yeah, some that got there listed there. Some of the ones aren't on the PBS. There's only one there that is on the PBS.
Yeah. So it's so it's an interesting one to be watching, but I think in future it's going to be considered more of a sexually transmitted, non-traditional STI, but still. So, but it can be quite distressing for people.
Yeah, if anyone is interested, I definitely recommend looking into the research that's come out, particularly looking at, because there is such a high recurrence, so people that have gotten BV, that it's very likely after treatment that it will come back within the next 3 to 12 months. There was some research looking into the treatment of heterosexual couples, looking at the treatment of a sexual partner, and the effectiveness of that on kind of decreasing the recurrence, and it was shown to be relatively effective at decreasing the likelihood that it would come back after treatment. But it's still kind of a very much preliminary kind of trials, but very interesting if you want to look into that. Highly encourage it there. So that is the last of the STI specifically that we're going to look at. There's long slog there. So we're nearly finished up. So we'll just touch on briefly about so just the reporting. So particularly those first few infections that we were talking about that are notifiable infections. And then we'll quickly look at contact tracing and then supports as well. And then we'll be finished up for today. So over to Garry talking about reporting.
Yeah, sorry, it's this is I think the first time we've tried to jam all this in to 1 hour. It's a lot, so I think I'm probably over talked a bit, but we'll try and do better next time. So so all of the STIs, chlamydia, gonorrhea, syphilis, hepatitis, HIV, etc., all notifiable infections. So for syphilis and gonorrhea, you have an enhanced surveillance form, which they want to dig out more specific details about the person who's been infected, treatment that's been given, confirm that contact tracing's been undertaken. So there's the HIV notification form, enhanced surveillance for gonorrhea, enhanced surveillance for syphilis, and all of the notification forms. And the one on the top left is the one that we primarily use for chlamydia, because syphilis and gonorrhea need their own special little form. They're all available electronically. So if anybody is still struggling with paper notifications, let me know and I'll send you all the links so that they can all be done online.
Briefly touch on terms of contact tracing. So obviously there's many different benefits or the reasons why we do contact tracing. One obviously is preventing or reducing transmission, and particularly we're talking about there, a lot of STIs don't have symptoms, are often asymptomatic or maybe not very obvious symptoms that may mean that somebody will go and get tested for that. So being able to kind of capture those who may be possible contacts, and then obviously reducing transmission from there, but also preventing reinfection as well. So if someone's coming in to get tested and treated, and they're going back and having sex with the same sexual partners that maybe haven't been treated, there's a likelihood there that they could be reinfected as well. So when we're encouraging people or talking to people about why it's important that we do let their contacts know, we can say from both aspects there, both for the other person's health, but also for their own health as well, if they are still in contact with that person. Of course, many different ways that this can be done. So in person, over the phone, and important, encouraging people to be able to do and contact trace, but also that there are different means that people are able to do this through. So for instance, we've got three images there. They are 3 sites that people can access that they can use anonymous messaging services. So they need is a person's phone number, also the infection as well that they possibly been in contact with. It'll send out an anonymous message that can't be traced back to the person who sent it out. And it will send them out a notification along the lines of letting them know that, hey, you've been identified as a contact. Here's some more information. We encourage you to get tested. So that's another option there. If maybe somebody doesn't have contact with past sexual partners anymore, or maybe for any other reasons that it may not be safe to, or they may not be able to contact them regarding this, they have got these other kind of avenues too. There is a new pilot project that's undergoing across Australia at the moment as well, which is around contact tracing of HIV. So there is a peer-led contact tracing program that is being run by Health Equity Matters, pilot program, and this program is using has employed positive people living with HIV to do the conducting the contact tracing there. So exploring how a peer-led model can help in terms of linking people to care, and also receptiveness as well when receiving these kind of notifications as well. So if you want to know any more about that, you can always reach out to WAAC and we can pass on more information to you. Anything else?
No, I think that's good on.
So lastly, we've just got some supports here as well. If you do need any more information, these are some kind of some services, but also sites as well that you can turn to. Of course, so M Clinic, they have the STI and HIV info line. That was the phone call we're getting through before. So if you have any questions, or if any community members have any questions around STIs, HIV, you're welcome to give the incredible M Clinic nurses a call and they can answer your questions. There's also SHQ, have also got a sexual health helpline as well. So staffed by sexual health nurses to answer any questions people have broadly about sexual health. Of course, ASHM, so any kind of trainings, resources as well, professional development. ASHM is kind of a one-stop shop there for that, specifically looking within an Australian context. And there are some also looking, you can can find them kind of state by state as well. So a lot of the information we got as well from these two bottom sources, which I'm sure you'd all be very familiar with. So the Australian STI management guidelines, and then also the WA Silver Book as well. There's some other resources as well. So there's the STI Atlas. So this is run by Melbourne Sexual Health Centre. So this is kind of one-stop shop for any kind of images and clinical presentations of different STIs. So maybe not one to look at when you're on your lunch break, but it's or letting people in the office know what you're going to be looking at. But that is, yeah, kind of a visual guide there as well. There is the Department of Health often are releasing updated versions. This is the most up-to-date version of the STI and BBB management quick guide as well. So it's available in PDF form, or you can also order physical forms as well from the Department of Health, similarly looking at the opportunistic testing for people with no symptoms, and then also the sexual health orientation manual for endemic regions as well, which also has got some good visual kind of guides as well around clinical presentations too. So that is, we'll wrap it up there. It's at 1:31. Can you take a breath? Yeah. Thank you all so much for joining the session today. So Steph's just resent through the form as well. We really appreciate if you have to take a moment just to provide any kind of feedback you have on the session. This feedback helps us to be able to do more sessions like this in the future. And also helps us to kind of, make sure that we're tailoring it to the needs of you all as in the healthcare sector in WA. So if you want to see more of me, or maybe more so if you want to see more of Garry, please, let us know. And we have had we've had a few workshops as well that we've done that you'll be able to access through our YouTube channel, which I'll send that out once we have the recording ready. But yeah, you're welcome to, you can either scan the QR code or also click the link in the chat. But I will stop the recording now. If you do have any questions, we are happy to take any kind of questions. Yes, so we'll be sending the slides as well. So once we have the